Lesson 6, Circulation, Hemorrhage, and Shock. So, we talked earlier about airway breathing, circulation, and the parts that go along with it. Now we're going to focus on the circulatory system. We said earlier that it requires 3 things to work effectively. It must have a heart that's pumping, it must have intact blood vessels to keep the blood in, and those vessels must be filled with blood. They must be filled with the right amount of blood, and hopefully the whole system is working together to deliver the blood to the target organs and tissues. So the metabolism is going to require energy to be produced. That is going to be in the form of adenosine triphosphate. That adenosine triphosphate, or ATP, comes as the byproduct of aerobic metabolism. So when the energy is created from oxygen and glucose and a ton of other chemicals going through the Krebs cycle, the byproduct is ATP, or that energy. If for whatever reason we have inadequate circulation, or going back, inadequate breathing, or an inadequate or poor airway, then we may not have the proper oxygenation, and we may have to switch to anaerobic metabolism, which we know produces only a little bit of ATP with a whole lot of acid production, and that's not good for our patients. So shock, which we said earlier, is going to be from inadequate energy to those tissues. Hypoperfusion could be one of the causes, and that could deliver or not deliver enough oxygen. So if we don't have enough blood flowing there, if we don't have enough pressure or volume of blood, or enough oxygenated blood getting there, then we are going to switch to anaerobic metabolism. So hypoperfusion for the trauma patient generally results from a loss of blood, either externally or internally. Now externally we should be able to visualize, see, and stop. Internally may not be found right away, but we should certainly be looking for the signs or symptoms of it. And again, like I said earlier, it's the most common cause of shock in trauma patients and one of the highest causes of mortality. An impaired pumping of blood from cardiac issues such as cardiac tamponade, or from a tension pneumo, which impedes or impairs the pumping of blood, or dilation of the blood vessels like in that neurogenic shock patient. We may have the right amount of blood, but it's in a much larger volume or space and not enough pressure. So the end result, we get a decreasing circulating volume of red blood cells moving through the capillaries, where the blood has to get through the body, get to the capillaries, and that's where it delivers the oxygen to the cells. It's also where it picks up the carbon dioxide and the acid from the cells. The waste products from the cells come back at that point as well. So if we don't have enough pressure coming in and bringing in the oxygen, nutrients, glucose, hormones, etc., we won't have enough pressure leaving, taking away the waste and trash. And that lack of oxygen impairs the metabolism and causes those cells to switch to the anaerobic metabolism. So the most common cause of shock, we said, due to hemorrhage. You're going to lose red blood cells, and those red blood cells are what carry the oxygen. So without it, we will decrease or lose the ability to carry as much oxygen as we normally do. For these trauma patients who present in shock, assume hemorrhage first, because that is most likely the cause of the problem. But assume there's hemorrhage. Look for it. Find it. If you can't find it, it may be internal. Start looking for the signs and symptoms. So when we look at the different classifications of shock, or the different classes of shock based on hypovolemia, so you see class 1, 2, 3, and 4. Class 1 is your beginning stages of shock, and this is going to happen early on with some blood loss. Not a lot there. You see generally less than 750 mLs. But it's about 15% of your circulating volume, which is about 1/6 of what you've got. So a little less than a liter, or anywhere less than a liter. You see that your pulse rate generally, it may be a little higher than normal for what's normal for you, but generally not too tachycardic. Your blood pressure is normal. Your pulse rate or your pulse pressure will be normal as well. And you see respiratory, all of those things look pretty good. Your urine output, which we generally don't measure, but they will in the hospital. Mental status, though, you might start to see a little restless or anxious, and those are very typical classic signs for patients in the early stages of shock. All right, give them a little bit of fluid, crystalloid fluids, saline or ringers, and generally we're okay. As you move into that class 2 shock, though, you see there you've got now a little bit more fluid loss. You're up to a liter, liter and a half, which is anywhere from 15 to 30% of your circulating blood volume. You notice the pulse rate started to go up. Blood pressure still normal, though. We may have a decrease in the pulse pressure, and you'll notice the respiratory rate is going up as well, and that anxiety is starting to increase also. So in the class 2, we've now got more blood loss, we've got a rise in heart rate, we've got a rise in the respiratory rate, and a rise in the anxiety level. As we move into class 3, here's where our classic signs of shock show up. We now have 1.5 to 2 liters of fluid loss, 30 to 40% of our volume. Look at the heart rate going up. Decrease in the blood pressure, decrease in the pulse pressure. Respiratory rate going up too dramatically. Urine output is now decreasing because the body is going to start conserving fluid, and so we'll stop making urine, or less urine, more concentrated urine. And you notice that the mental status now may go from anxious even to confused. This is our drop off from the compensated shock into the decompensated shock stage. As we move into class 4, more than 2 liters of fluid loss. Blood loss is 40% or more of your total circulating volume. You see the pulse rate there. Now we're up to 140 on the rate. Pressure decreased, pulse pressure decreased, respiratory rate greatly elevated, almost no urine output at this point. We know that the kidneys are probably not being perfused well, and confused and lethargic, even obtunded or unresponsive at this point. So your patient has gone from a little bit of blood loss with very little negligible changes to a little bit of heart rate, a little bit of respiratory rate increase, and a little bit more anxiety. And now we start to get into the decreased blood pressure in stage 3, and decreased pulse pressure, rising heart rate, rising blood pressure, more and more anxiety and confusion, and worsening signs into class 4. And these are when we need to prevent this from happening. We need to catch these early. That anxiety and restlessness in class 1, very early, typical early sign that's seen most often in these patients. And then as we move into 2, 3, and 4, your patient is getting worse. So distributive shock, or that neurogenic shock, this is going to cause a loss of sympathetic stimulation. And when this happens, the blood vessels are going to dilate. And also because we don't have this sympathetic stimulation to the heart, we may not get the rise in heart rate that we're used to seeing. So you get an increase in blood space, or the blood vessel space. And some of you may remember this back in the day as called high space shock, or relative hypovolemia. We now have a bigger space with the same amount of blood. So your 1 gallon of blood in a 1 gallon container is now 1 gallon of blood in a 5 gallon container. So the pressure's a lot less. So this neurogenic shock, we're going to have vasodilation, and also not a rise and increase in heart rate to compensate. In fact, your heart rate may be normal or slightly less, or even bradycardic. So we don't get the compensatory raise in rate, and we've got a massive dilation of blood vessels. Cardiogenic shock, we said, was intrinsic or extrinsic, and it's usually going to be an extrinsic issue that's going to cause us problems. But some of the intrinsic problems that may result, dysrhythmias, valvular disruption, we may also have, we could also have an MI due to cardiac contusions. So we could have that happen as well, and that may impair or impede blood flow or the ability of the heart to contract effectively. And the extrinsic factors, the tamponade and the tension pneumo, which we said will impede or pressure the heart and keep it from filling and pumping properly. And tension pneumo can also impede blood return through those vena cava as well. So this will all decrease cardiac output, which will have an effect on blood pressure. So as far as assessment goes for these patients, let's look for hemorrhage first of all, and that's why it's in the ABCs, airway, breathing, and circulation. We've got to look for and control hemorrhage. If it's an exsanguinating hemorrhage, you have a patient who has a femoral artery bleed or brachial artery bleed, those need to be stopped immediately. Consider tourniquets early for those patients, direct pressure and tourniquet. Level of consciousness, if your patient is anxious, restless, if they are confused, disoriented, or obtunded, maybe a complete loss of consciousness, those patients are in bad shape. Early on, that restless and anxious is a very early sign that patients get when they're starting to go into shock. Look at their skin, color, temperature, moisture. We'll look at pulse rates, distal and central pulses. We'll look at respirations, blood pressure, and some other factors that go along with it. So hemorrhage if it's seen, must be controlled immediately. External hemorrhage, which we should see or look for, needs to be addressed with direct pressure, or consider tourniquets early, especially for your limb arterial bleeds. Internal bleeding may not be seen right away, but we should certainly look for the signs and symptoms. If you are doing a fast exam using ultrasound, or an e-fast exam, which also looks for pneumothoraxes by looking at mid-axillary views of the lungs, that may help address abdominal bleeds if you're doing the fast exam. However, don't delay transport to do these exams, and make sure we transport the patient to the appropriate destination. Decreases or changes in the level of consciousness, especially early with those restless and anxious, and I say those words over and over again because those are the classic signs that people see in patients in the very early beginning stages of shock. But as the brain gets less and less perfusion, you're going to see a worsening or decreasing altered level of consciousness, and eventually your patients will be unresponsive and obtunded. And again, as that level of consciousness decreases, their ability to maintain their airway, their ability to keep their airway protected, all decrease and put them at risk for other issues such as vomiting, aspiration, etc. In checking the skin, we're going to look at the color. Hopefully it is the normal color for the patient, which for us may be difficult to assess. Temperature, though we would like it to be warm. Remember, hypothermia, one of the triad of death sides, so we want to make sure that we keep the temperature warm, cover the patient if we need to. Moisture, we'd like it to be dry as well. In early signs of shock, patients will get cool, clammy skin, so temperature and moisture, and capillary refill, which can be difficult depending on the ambient temperature, but remember, delayed capillary refill, generally a sign of hypoperfusion to those distal extremities. We also want to check the pulse, looking at distal and central pulses. So compare the radial pulse to the carotid pulse to determine strength. We want to know the rate. Early signs of shock will show some rise in heart rate, and as we move later and later into class 2, 3, and 4 shock, we're going to see a rise, bigger and bigger in the heart rate. Very late and very poor signs would be if the heart rate suddenly starts to decrease or they become bradycardic. Quality, the strength of pulse. How is our radial pulse? Is it weak? Is it bounding? Is it thready? And the location. If we cannot get a radial pulse, can we get a brachial or a carotid pulse? For respirations, as patients become hypoxic, if they are hypoxic, they are hypercarbic. Remember, hypoxia means low oxygen, and if you've got low O2, then you have to have too much CO2 going on. And that hypercarbia is probably coming from the acidosis that's arising, and that will stimulate you to breathe. So that hypercarbia coming from the acidosis changes the pH and changes the CO2 levels, which is going to make the brain start to breathe. The problem is, as you get worse and worse and worse, you're not going to be able to breathe effectively, and as you're breathing, you're using your glucose stores, and you're going to eventually build up more lactic acid, and your muscles will get tired and fatigued, and then you may not be able to breathe well at all. Oxygen helps to reduce that hypoxia. If they cannot tolerate the mask, which typically happens in patients who are hypoxic, they get claustrophobic, they start pulling at the mask. That may be a patient who's already hypoxic, and just a simple face mask or oxygen non-rebreather may not be enough. You may have to start bagging that patient because the hypoxia could be getting worse. As far as blood pressure goes, it is not a good early determinant of shock. We've already said that mental status is first, and heart rate is your next thing with respiratory, and then at the end you see the blood pressure drop. So don't rely on it and look at the number and say, well, he's got a good blood pressure now, therefore he must be okay, because it could drop later on. So that's why it's really not part of the primary assessment, although we do want to get an early set of vitals, airway breathing, circulation with pulse, skin, and other things that show more likely to indicate a problem with the perfusion. So we do want to, though, get an early blood pressure to see any trends that are occurring. Is the blood pressure going up, down? We want to look at pulse pressure and mean arterial pressure as our indicators of whether patients are in shock or headed towards shock or not. But we do not necessarily want to treat patients to get the blood pressure back to normal. In order to get them from a low blood pressure back to their normal blood pressure, which may be high, we need to give them lots of fluid. And we've talked about how fluid is not necessarily the best treatment for patients because of the problems that come out of it. Some other things that may cause patients issues: their age. Elderly patients do not deal as well with trauma. They don't have the elasticity in the vessels to constrict as well. Plaque buildup may cause poor flow of blood through vessels. They may also be on medications like blood pressure medications, beta blockers, calcium channel blockers that may interfere with heart rate increases, or medications that are designed to keep the blood pressure lower. Some blood pressure medications are designed to cause vasodilation. So we have all sorts of things that may actually counteract or interfere with your body's compensatory mechanisms. Pregnant patients have higher heart rates, lower blood pressures, higher blood volumes. They have issues with airway as well, and those may all cause problems. And pre-existing conditions such as patients who are hemophiliacs, things like that, those patients are more prone to bleeding as well. And though not hemophiliacs, a lot of elderly patients are on blood thinner medications, which does interfere with the clotting, which puts them at higher risk for bleeding as well. So always assume that the patient is bleeding somewhere, even if you can't see it. A lot of times it may be internal from either internal organ injury, could also be from fractures as well. Every long bone has an artery and a vessel, a vein running next to it. So it could be disruption of one of those vessels. But internal hemorrhage, start looking for the signs and symptoms. Vital sign changes, changes in mentation, bruising, contusions, swelling, distension, etc. That may lead you to believe there's an internal hemorrhage. If it is internal, remember that there's a lot of blood in the chest and abdomen, and that blood may be hidden for a while. You can't hide the vital sign changes though, so look for those. But the chest, the abdomen, and even the pelvis can hold a significant amount of blood before you start to actually see it externally. The chest will generally have visible signs of trauma from either penetrating or blunt trauma. The abdomen may not until later on. When we're looking for internal hemorrhage, and here's a picture of a patient, you can see this large contusion there on the left side, just to the left of the umbilicus there. There's your left limb lead. The red lead there above it. So you know we're looking at the left side here, so this would be a concern for us to think about something in the spleen area. And those internal hemorrhages can cause a significant amount of bleeding that may stay hidden in there. The liver, the spleen, and even the kidneys have a significant amount of blood flow that can be hidden for a long period of time before it's finally visible to the external surface. If you have patients with abdominal injury, and they have hypovolemia or vital sign changes indicative of it, assume that there's a bleed going on in that abdomen. This would be a perfect candidate for the fast ultrasound if you are doing those sort of examinations in the field. Fractures such as these of the pelvis can cause a significant amount of blood loss into the tissues. We have very large arteries moving through these areas. Your aorta that comes down into the abdomen actually branches off into the iliac arteries going through here, which then will turn into the femoral arteries. A lot of blood moving through this area, so there can be a lot of blood loss in here. Head of the femur area, pelvic fractures, these areas, significant blood loss to these areas. And again, may stay hidden for a while before you notice them, but you should notice some vital sign changes and mental status changes before you notice externally that there's any presentation from the bleeding inside. Penetrating injuries, and again here we're looking at a knife in the, looks like a knife into the chest. And again, depending on the area where it's at, it's kind of on the borderline there between the abdomen and the thorax, and the angle of it would indicate that the knife is probably going down into the abdomen. So again, we've got the spleen there on that side. You've got a lot of mesenteric vessels in there. You've got, depending on the depth of the knife, you could have back into the kidneys. So we want to try to follow that path as much as we can and try to figure out what it may have hit, but definitely look for signs of internal bleeding with this patient, as long with stabilizing the knife and all those other things. And remember, never remove it. For blunt injuries, the path injury is not always visible. You can see where the impact occurred because you will probably have some sort of external hemorrhage, contusion, something like that, but you may not know internally where the energy went to. But it will go through the trunk, out, it can go into the extremities as well, and it can go through the organs, causing disruption of the organs, fracturing of the liver, or lacerating of the liver and spleen. Also the kidneys as well. It can damage the bones, which could in turn damage vessels that lie next to them. So the potential for bleeding is very, very possible with these patients. And in blunt trauma, we tend to see multi-system, not just one area, but multiple areas that get injured, as opposed to the penetrating injury, which generally follows along the path of the penetration. So for the blunt injuries, we can have compression. We can also have cavitation, deceleration, such as in a motor vehicle accident when patients are seatbelted in. That sudden deceleration will stop the body, but it doesn't stop the organs on the inside that continue to move, and those can tear or shear. The heart can tear off the aorta can tear, the brain, the axons can shear. So we have a lot of different possibilities with these patients. Those damaged organs, tissues, blood vessels, again, can all bleed into the area. That bleeding is decreasing the amount of oxygen delivered to them, and that bleeding can also put pressure on vessels and organs, causing more pressure issues and causing them to have more lack of perfusion. And as the amount of blood increases, we know that the signs of shock are going to start to develop, starting with those mental status changes and then eventually heart rate, respiratory, and then at the end we may see some blood pressure changes. So some of the injuries that you might see most often with hemorrhagic shock, if you've got the aortic rupture, there is a really good chance your patient is going to die. This is a significant amount of blood to come out of these vessels, and it really depends on the damage and how much tearing there is of the aorta. But most of the patients here are going to die. They're going to bleed out into their thorax. This is just over the junction, so where the aorta comes out of the heart and you see it come up and over the heart like that, you see right there in that bend, that's usually most often where it happens. There's also a ligament that holds the aorta in place called the ligamentum arteriosum, and sometimes that will tear or rip through the aorta as well, again causing massive hemorrhage for those patients. But again, most of these patients probably are going to die relatively quickly, and the most common cause of this is from a high-speed sudden deceleration. Motor vehicle crash at high speed into a wall or tree, patients who fall, those patients, it's the deceleration or the stop that causes this to tear. Hemothorax, they're bleeding into the lung. So we talked about this in the breathing or ventilation section, but you're going to get blood leaking into the pleural cavity, and you can actually end up with a significant amount of blood flow. Remember, each hemothorax, each one, can hold 30 to 40% of a patient's blood volume. So if you had a bilateral hemothorax, theoretically, you could be holding up to 60% of the patient's blood. And for just about every patient, that would be enough to kill him. Remember, 40% blood loss showed significant mental status, heart rate, blood pressure changes. So if you were to have a bilateral, you'd be talking a significant amount of blood loss, and that would be very bad for your patient. Again, nothing we can do for this in the pre-hospital environment. Recognition, and get them to a hospital as quickly as possible so they could get in there, stop the bleeding. Some other things you might see in the abdomen, we said the solid organs like the liver, spleen, kidney, pancreas, those things are going to have some significant bleeding. Solid organs bleed, and they can bleed a lot. There's a lot of perfusion going through the kidney and liver, your spleen as well. So anything that damages them, from tears to penetrations to compression injuries, those can all cause significant amount of bleeding in there. You may also see, especially with the pancreas and with the kidneys as well, or bladder, you may see some loss of urine. You may see the loss of, if there's intestinal injury, you may see the loss of bowel matter into there, which in the beginning will not kill them, but the resulting infection can definitely cause sepsis in these patients. The hollow organs, like we said, the small and large bowel, again, there's your big cause of fecal matter, peritonitis, things like that that can cause significant shock down the road. So fractures. Fractures can cause blood loss as well. Remember, we said earlier that there's a artery and a vein running alongside each one of your long bones. So you have a brachial artery and a femoral vein coming back, and they're all carrying a significant amount of blood. So if you have a fracture of those that damages those blood vessels, then you could have a lot of blood loss, and that blood can be hidden inside there because you may not see it in the thighs, in the pelvic area, etc. So we see there each rib, you see 125, the radius and ulna, we're almost up to a ½ liter, and the humerus is 750. Now remember, 750 was our cutoff for class 1 shock. When we start to get into tibias, fibulas, femurs, we start to get into just one femur is enough to get us into class 2 or class 3 shock. So if we had bilateral femurs, or if we had a femur and a pelvis, you could very easily go into class 2, class 3 shock very quickly just from those single injuries. So there's a lot of blood loss in there. And again, your thighs, your pelvic area, they can hide a lot of blood before you start to see it, but the vital sign changes should be occurring, and that's what you need to be looking for. So in those rib fractures, again, we said earlier in the breathing chapter that they tend to be mostly in the middle sections of the ribs, not the first 3 up under the clavicle or the first top 2, but those middle sections of your ribs there, ribs 4 through 8. And generally you can see some injuries to the vessels underneath there, as well as the liver and spleen as well, or the lungs with pulmonary contusions or actually penetrating injuries into the lungs. So the injuries we see from the distributive shock, which we said was the neurogenic shock, again, some of you remember that as high space shock or relative hypovolemia, but usually it's a spinal cord injury. And usually you might see it in the cervical spine down to the mid-thoracic. Remember, the most common injuries to the cervical spine or to the spinal cord itself are the cervical or the lumbar. It's rare that we see thoracic spinal cord injury, but it does happen once in a while. So what you'll have there is the blood vessels will dilate. That will cause that high space. You have the same amount of blood, there's no blood loss. But because there's less space or less blood in that space, or more space depending on the blood, however you want to look at it, you have a much larger space to blood volume ratio, and therefore your pressure decreases and you end up with less preload coming back to the heart. So because of that, you end up with a drop in cardiac output. Your perfusion and tissue oxygenation are usually maintained. Your skin is warm and dry because when we vasodilate, blood tends to come to the surface of the skin, giving us a warm and sometimes flush look, as opposed to the hypovolemic who vasoconstricts the blood away from the skin, giving you that pale, cool feel. For the cardiogenic shock, for the 2 most common causes, we said were the pneumothorax and the pericardial tamponade. For the pneumos, we talked about the tension and the simple already in the breathing chapter, but just to remember, the big change that you're going to see with a tension versus simple is very significant ventilatory distress. You're going to see an increasing and worsening ventilatory problem no matter what you do for this patient. Simple pneumos, for the most part, as long as it stays a simple pneumo, will generally plateau at a level and should be helped or assisted with oxygenation or ventilation of that patient. In the tension pneumothorax, oxygenation, ventilation, nothing will help them, and they will continue to get worse. And as they get worse, you will start to see that hemodynamic compromise as we get the shift in that mediastinum, pressure on the vena cava and heart, causing a decrease in blood return in and cardiac output coming out. So that's the big difference that you want to see there. And if you have that tension pneumo with that marked hemodynamic compromise and that ventilatory distress and probably a decreased or altered or complete loss of consciousness, that patient needs to be pleurally decompressed. For the pericardial tamponade, what we're looking for here is generally from trauma to the chest, blunt or penetrating, we're going to get blood filling in the pericardial sac around the heart. So as the blood fills in around the heart, it will compress the heart, which does 2 things. It doesn't allow the heart the ability to fully relax, which decreases its fill. And because it's not filling properly, it won't expand, and Starling's law said the greater the expansion, the greater the force of contraction and return. So we can't relax, which means we can't fill, and if we can't fill, we can't expand in order to contract more effectively. So our cardiac output is going to go down. We have less fill and less contraction force coming out. So cardiac output decreases, blood pressure goes down with it. So some of the other things that can happen, you might have that dysrhythmia. You may have a contusion to the heart that may also cause MI. Sinus tach is what we're going to see most often as a compensatory mechanism trying to compensate for that decreased volume. You might also have a ventricular rupture. You might also have a valve rupture. Listening to heart sounds may identify that. Or you may have sudden death, a condition where patients get a significant blow to the chest puts them into sudden death. All right, so some things to ask about. The cause of shock for the patient. So things that you want to think about. What's the most common cause of shock? We said it was hemorrhage. And the care for that is to stop the bleeding. You need to stop the bleeding as quickly as possible, whether that be through direct pressure, tourniquets, and if it's internal bleeding, you should definitely be getting that patient going to the hospital, definitely somewhere where they can get surgery, a trauma center for that. What can and should be done now between the time the patient reaches the definitive care? Assess, reassess, make sure your airway, breathing, circulation, make sure all of those things are taken care of. Do your secondary survey if you have time, but don't waste secondary assessment time when you should be doing primary stuff. And the best place we know for them to get the definitive care is in the OR. All right, so remember, shock management also helps us to improve the oxygenation of red blood cells and deliver those red blood cells to the tissue. So airway, we need to make sure that it's clear. Ventilation, we need to make sure that they're ventilating properly, and if not, do we need to assist them or do we need to do it for them through intubation or the use of a supraglottic airway? Will bagging help enough, or do they just need some oxygen, supplemental oxygen for that? Circulation, control that hemorrhage, control it early, stop the bleeding, save the blood. That's what's going to carry the oxygen that we're trying to give them. As far as position goes, most of our trauma patients are placed supine. Trendelenburg as a position is no longer recommended. There have been numerous studies over the years that have shown that Trendelenburg really does not help and is probably, for a lot of patients, going to impede certain things. Remember, when you put them Trendelenburg, the abdominal organs are going to move up, and that will impede the ability of the diaphragm and ventilation to occur. And for your obese patients, this can really have a major effect on their ability to breathe as well. As far as raising the legs, like we were taught so many years ago to treat shock patients, again, this really hasn't been shown to be beneficial for patients and therefore not recommended, especially in trauma, because if they have any injuries, pelvic injuries, lower back injuries, or whatever, you may exacerbate those. For the hemorrhagic shock patient, again, stop the blood flow. External, we can stop it. Internal, find it. If you can do a fast exam, great. It's very good science that shows that it's good in identifying internal bleeds. Remember, every little blood cell counts. Every red cell counts. We need to save as many as possible. All right. Yes, the patients can get blood when they get to the hospital, but we can just stop it now and let them use their own blood. It's much better for them now because you just don't go to the hospital and order up a blood and poof, it's in you immediately. You have to cross-type and match, get it from get the blood, and there's a long process that they have to go through at the hospital to give it, and you want to make sure that the patient really has their own. And also remember that blood loss is taking away heat as well, and hypothermia was one of those sides of that triangle or the triad of death that we talked about. All right, so direct pressure, again, tourniquet, immobilize those fractures. Do not let them move because the blood vessels right there can become torn or get cut from these fractures, so we want to make sure that we immobilize those fractures. The use of hemostatic agents can help as well. These devices have been used and tested by the military. They can help stop bleeding, but it needs to be packed into the wound to help with those. And then the internal hemorrhage, again, they've got to get them to the trauma center because they've got to go to the OR. That's where they're going to fix those bleeds. All right, so direct pressure, right? Pressure bandage and dressing, and if that doesn't work, like we said, tourniquet if it's on the extremity. If it's in the trunk of the body, then we'll use those hemostatic agents to help control that. If it's an internal bleed or if it's a bleed you cannot control, get them to the hospital as quickly as possible. For the hemorrhagic shock patient, fluid resuscitation, and this has been an ongoing debate for many years. And so basically what the general thinking is now is that you really need to balance how much fluid we're giving as to how much we want to raise the blood pressure in these patients. Excessive fluid generally leads to more bleeding, which is not going to be beneficial for the patient. We might get the blood pressure up, But at that point, the blood pressure is really just water pressure because we're giving too much fluid and they're not circulating enough blood. Fluid dilutes clots. Fluid can cause clots, or pressure can cause clots to become dislodged, and it dilutes the clotting factors. All of those things not good for patients. So for patients with hemorrhagic shock, all right, maintain a blood pressure between 80 and 90 systolic. Now this may be quite a change for people because we're so used to that 90 or above number, but between 80 and 90 systolically is where it's okay, because that will give us enough mean arterial pressure to supply the kidneys, the brain, etc. These patients will be supine. They're not going to get up and walk around where you expect the blood pressure to drop, but between 80 and 90 systolically. If they have signs of a head injury, all right, then we want to aim up a little bit higher. Now, other classes and what you may have learned in school go even higher than this, but for PHTLS, we're looking for a blood pressure between 90 and 100 systolically. All right? Preferably, your fluid should be warmed. If you're in Florida with air conditioning, that fluid in the back of your truck might be at a temperature of around 74, 76, 78 degrees. And remember, when we give lots of fluid to patients that is cold, that may lower body temperature. And for trauma patients, that hypothermia is not a good thing. Pediatric patients, 20 cc's per kilo fluid bolus for them. Okay, so again, warm would preferably be the best if we could. All right, so after we give the fluid, a couple of things. If we see a rapid response and the pressure comes back to normal, then it probably has controlled the bleeding. Still might end up going to surgery, but at least for now it seems that the hemorrhage has stopped. If you see a transient response, meaning it kind of improves but then starts to go away again, they're probably still hemorrhaging. You've temporarily fixed the blood pressure issue, but there's still hemorrhage there and they definitely are going to end up in surgery. And if you see no response at all, you have done nothing for them, they are still bleeding out, and you've really got to get them to the hospital quickly so they can get treated properly. For the distributive shock, again, make sure there's no hemorrhage. Always look for hemorrhage first, but make sure there's no hemorrhage. Spinal motion restriction because of the probable spinal cord injury, and fluid administration. We want to try to add to those pipes to fill them up a little bit to give us some better pressure. As far as the cardiogenic shock goes, for the tension pneumothorax, decompress that. For the pericardial tamponade, rapid transport, fluid administration, there's been some kind of a few things with that, but some fluid administration, you just want to be careful. If they end up with too much fluid and they don't have enough cardiac output, they may end up backing up into the lungs. But they do need pericardial centesis. There are some departments in Florida that do that, but they do need to be centesed. And if it's an intrinsic issue such as a dysrhythmia, we'll help treat that. Again, watch for fluid overload with these patients. Again, if they're not able to pump effectively, that fluid may end up backing up into the lungs. Transport without delay. Get them to the proper facility. Get them going where they need to go, and do most of your stuff that needs to be done en route to the hospital. Don't delay on scene doing things. If you're waiting for the helicopter to come there, then you may have some time to do a couple more things, but do not delay your transport if it's available. And maintain the body temperature. Keep them warm. Trauma patients need to be kept warm. Your medical patients, your MI patients, the patients who survive cardiac arrest, the targeted temperature management for them, yes, cool those patients. But trauma patients must be kept warm. So after you expose them, make sure you cover them. Air conditioning in the back of the truck should be off. Nothing blowing, nothing fanning, nothing. Keep them covered, keep them warm. Remember, that's one of the three things of the triad of death. So your prolonged transport, make sure you got airway going, make sure your ventilation's going. Airway, breathing, circulation controlled, prevent heat loss, so expose and keep them protected from the environment, and reassess, reassess, reassess. Reassess the airway, reassess the breathing, reassess the circulation, going along with your vitals, your blood pressure, heart rate, etc., CO2, pulse ox, all of those things. Reassess the things that you treated, reassess the things that could go wrong. You think there might be an abdominal bleed, keep reassessing, looking for tenderness, rigidity, looking for bruising, anything that may show up. Reassess the vital signs to go along with it. If you have a long transport, you should be doing nothing but reassessing the things that could go wrong and the things that you tried to fix. If you don't treat shock, it will eventually progress and get worse and kill your patient. Our goal is to recognize it early, do what we can to stop it or prevent it from getting to that point, help the body by giving fluid, by giving oxygen, by restoring perfusion, by doing the things that we can do that will help it do better. If you do not intervene, the compensatory mechanisms of the body will only work for a certain limited amount of time, and we know that as those things continue to decrease, ATP production decreases, lactic acid increases, so there's no energy, there's more acid, there's no oxygen, hypothermia sets in, coagulopathy set in, and your patient is going to die. All right, so some other things we can do. We talked about the hemorrhagic shock. Make sure that that is what you're looking for. Make sure that is what you're looking for until proven otherwise. Assume that it's a hemorrhagic issue. External we should see, look for the internal. Cardiac output we want to make sure are good. Tissue oxygenation needs to be supplied because those get impeded early, and so we want to make sure that we help fix those. Restore and maintain the airway, ventilation. Again, hypothermia, do not let them get cold. Keep them covered, keep them warm. Especially on cool days, cool nights. Keep them warm. Blanket, keep them covered. Transport as quickly as possible without delay. All right, this ends this section. Please review and do the questions for this section. Thank you.